When the muscle comes down, percentage body fat goes up. And those patients that muscle goes up, percentage body fat goes down. So it opens up the gap, right? So anytime there's muscle gain, there's percentage fat lost automatically without medications.
All right, welcome back to the podcast. I am joined today with Dr. Rocio Salas-Whalen. She is the owner of New York Endocrinology on Park Avenue in New York. She has a deep expertise in diabetes, metabolism, obesity, thyroid abnormalities, and other endocrine disorders. And today we will be diving into specifically obesity. She did her internal medicine residency at Albert Einstein College of Medicine, endocrinology fellowship at the University of Maryland, and she did a research fellowship in Johns Hopkins, where she published some papers, and now she does full-time, it seems like, obesity management. And I have become acquainted with your work through Instagram at, I think, let me see, what is your handle? It's New York Endocrinology, right?
Correct.
And yeah, so I was thinking where we could start, kind of maybe paint the picture of how you got into helping people with obesity. And then I'd like to get maybe into your approach, like how you take a history and go from there.
Definitely. So I'm from Mexico, and in Mexico, diabetes is the #1 cause of death. So going into medical school, I always knew that I wanted to work with diabetes, and type 2 diabetes specifically goes linked with weight, goes linked with lifestyle, right? So it's a relationship. They go hand in hand, type 2 diabetes and weight or lifestyle, right?
Right.
You can treat one without treating the other, basically. So my dive into endocrinology was diabetes and metabolism. And through my fellowship, I started to get more interested in obesity, in weight loss, and having more information and being, removing bias in obesity. Like, it really opened my view and my mind into treating obesity, right? And it's a conversation that all of us physicians encounter one point with our patients, and it's a long, deep conversation to have. And I feel like having a specialty in endocrinology and obesity allows us to have more of that discussion, or more deep discussion, right?
Yeah, I think your background in endocrinology really positions you well. And for you, you were talking about how obesity is more about total metabolic function, or tell me, like,
And being an endocrinologist, I still did obesity medicine. I got board certified in obesity medicine. And I mean, the knowledge that you gain doing obesity medicine versus endocrinology itself, there's a big, vast of a difference, right? Many things that we're not taught in medical school or residency or fellowship regarding obesity, right? So obesity, the term and the definition of obesity has changed significantly in the last years. More ago in Europe, in 1942, the WHO classified obesity as a chronic disease. But it's not until 2013 that the American Medical Association adopted it and accepted as to classify as a chronic multifactorial disease, right? Before, it was considered more of a lifestyle problem. It was the eat less, exercise more, and then come back, and nothing was happening, right? Now we can actually accept it as a chronic metabolic multifactorial disease, right? So that's where we are now. And then came COVID, and COVID really pushed obesity more in our face, right? Like, you as physicians and what we tell patients is, if you don't take care of your weight, and you don't lose weight, in 10, 20 years, you might develop type 2 diabetes, hypertension, all these chronic conditions that we know could happen with obesity, right? But what happened with COVID? It hit us out of nowhere. And all the studies show, and you can go to PubMed, and there's so many studies that show that patients with obesity or higher BMI had more severe COVID, higher admissions to the ICU, and higher mortality, and higher need of mechanical ventilation, so intubated patients, right? So I feel like COVID did something positive and has brought this light to obesity. I had a lot of influx of patients coming in and saying, I'm scared. I know I'm overweight. I know that I have obesity and I don't want to get really sick with COVID. So I feel like COVID really put it out there that obesity is causing some sort of inflammation, some sort of problem, that we don't have to wait 20 years for a complication. Came this virus out of nowhere, and it was the highest mortality people with obesity, right? So I feel like people really got the message, the general population and us as healthcare providers.
Yeah, I remember there was someone had posted on social media how like that was just not true, how obesity wasn't really increasing mortality. And I remember looking back at the study, and specifically it, like, I didn't understand how that person, I don't even remember who it was, but how they got to their conclusion that it wasn't a big deal, because it is a big deal. It does increase mortality quite a bit. Can you speak to the controversy of that?
So what happened is that many of the studies were initially done in Europe and in Asia. So there's the rates of obesity are not as high as in the United States, right? So when it came to the United States, COVID, because first it was all Europe, right? They started COVID with the pandemic, and then it came to New York, and then the rest of the country, right? But when the patients were coming here, and it was in NYU that did that first study, that it showed that the patients that were being admitted to the ICU were related to BMI, right? And now looking back to Europe, now they have their own studies showing that yes, even though obesity is not as high, the patients that were having severe COVID were the ones that were overweight or had obesity, right? And all the studies show is because there's chronic inflammation in obesity, right? So when there's chronic inflammation, your immune system is being preoccupied with the chronic inflammation in the adipose tissue. Then came the virus, and it didn't have enough immunity to fight the virus. So that's in a simple way to say what's happening with obesity and COVID, right?
Okay. Yeah. And just for my audience, in mental health, so often we see people and we're not thinking about weight at all, honestly. So it's good to have this conversation so that we could start seeing it as like, okay, this is increasing inflammation and can potentially cause a ton of issues. But even worse than that, often we are putting them on meds, which increase weight, right? And so, go ahead.
Really interesting that you bring mental health, because mental health is something that we don't associate so much with obesity as a consequence of obesity, right? But I feel like my perspective towards obesity has changed through the last 3 or 4 years that I've been practicing clinically with obesity. I think 90% of my practice is obesity. And going into what history or how is my evaluation is, I go very detailed in their weight history. I always ask the patients this question: how young were you? And I'm an adult physician, right? So most of my patients are 20s, 30s, 40s, 50s, 60s, right? But I always ask my patients, how young were you the first time that you remember that you had something with weight, that you had a weight issue, that you had to think about food, that it was part of your life? Childhood, 9 years old, puberty, 10 years old. So I have a 30-year-old, a 40-year-old, a 50-year-old patient that throughout their teenage years, their young adult life, their 10, 20, 30 years, their life has surrounded around their weight, right? Around that plate in front of you. How is that going to impact my weight? How is that going to impact my diet moving forward? So that takes a toll into mental health. So I've had grown men cry in our appointments because it's so emotional. It's such a deep, personal, emotional journey that the patients had. And it's very similar for every single patient. I've never met a patient with obesity that is that idea that we have, that they're lazy, that they could do better if they wanted, that they're there because that's their lifestyle. every single patient when they come to me, I mean, David, they tell me about diets that I've never heard in my life. They've gone through call it fat camps, nutritionists, a physical trainer,
Mm-hmm.
all the diet de jour, all the
Right.
books. They've done their legwork, and it's not
Mm-hmm.
working. So that's not the problem. It's not the lifestyle. It's not what they're doing or what they're not doing. And knowing that, it relieves the patient from a lot of pressure, right? And talking about mental health and obesity, and why changing the way we view obesity is going to relieve a lot of those patients from that pressure and that guilt, right? And also open their mind to go and ask for treatment, right?
Yeah.
There's that idea that, oh, this is the easy way out. But we wouldn't think that of in a type 2 diabetic if they go and look for medication and treatment, right? It's just that bias that we have regarding weight and weight loss medications.
Right. So, yeah, 100%. I mean, food is comfort, food is culture, food is like I've had my fair journey, it's like I could almost be a patient of yours. Um, but and mental health is so intertwined. Often in mental health, we're seeing anorexia, bulimia, and people who have anorexia, they could be very slender, but they still believe they're fat. And people with bulimia, they could, it could be like an impulsive sort of cluster of issues that leads to that, or the fear of getting fat, or a disgust towards food. I mean, there's a multiplicity of reasons why people have bulimia. And then we also see people who aren't eating because they're depressed and they just lost the desire to eat, and those, like the severe melancholic depression, tends to be that way, where they just stop eating and drinking. Maybe I've had a couple of those patients.
Yeah.
So, okay. So where I'd like to go is kind of like, as you're taking the history, what are things that you ask now that maybe, as an internal medicine doctor, as an endocrinologist, you didn't ask before? And what are some things that kind of like are part of your history taking that you've learned to kind of include in the history?
So definitely family history plays a big role. And I as far as up as I can go, or as far as the patient has knowledge of, right? So I always ask about the parents' weight history, life. I mean, I don't want a number, but I want to know if they've struggled with weight or they're conscious. And many times they say, oh, no, they're normal weight. And I ask them, is it conscious? Do they exercise? Are always watchful? I mean, or is this more of a natural? Oh, no, my mom eats very little, or no, my mom goes to the gym a lot. So even getting that information, uncle, like siblings from the parents, I always want to find out where's the obesity gene coming from, if there is any, and I would say in 98% of the cases there is, right? I ask about siblings, and depending on their age, children, how's the weight of their children, how's their health of their children if they're teenagers. And I mean, there's a very strong familiar link, right? So then we add that genetic part to the multifactorial causes, right? Then I ask about if they're female, their menstrual history, right? If they have regular periods, irregular periods, just trying to get some history of PCOS. So in male also, if they have obesity, libido, erectile function, because that can guide me hypogonadism or not, either due to the obesity or the obesity causing the hypogonadism. There could be some relationship. I asked them about siblings, same thing, right? So a very detailed family history. I asked them about lifestyle, right? What is your lifestyle? Do you exercise? What type of exercise do you do? What are your eating habits? What's your relationship with food, right? And then job. Sleep is always, is very important as part of my question. How do you sleep? Do you sleep well? Do you sleep throughout the night? I mean, I would say the majority of patients don't have proper sleep, right? And that's one of the environmental factors that can contribute to obesity. A lot of patients travel. If they travel for work, then that's environmental factors too, right? Stress, traveling, flying, being in airports, not having access to normal routine food that the patient would have, right? That contributes to obesity too, right? And then, I mean, age, Medication, for sure, medication list always, right? I mean, we know there's a lot of weight gaining medications, antihypertensive, psych medications, right? So it's a very detailed history, right? I dig very deep in their medical history and in their lifestyle too.
Yeah, that's so important with like sleep. How often do you uncover something like sleep apnea, and how does that play a role in obesity?
Many times, because that it's just like a vicious cycle, right? So
Yeah.
if they're not sleeping because they have sleep apnea, then they're not sleeping is raising their cortisol, and that can promote waking and obesity, and then they're just feeding each other, right? So many times patients, they're not aware that they have a sleep apnea, but then when you start asking, do you snore? Does your partner, does anybody complain of your snoring? Do you have deep dreams? Do you remember deep dreams? So it's just getting a little bit more history into their sleep, right? So it's a very detailed visit.
Yeah.
And that's more my clinical questions. Then I do have like an InBody machine in my office, which is, it's an impedance. It tells you about skeletal muscle mass, visceral fat, percentage body fat, and it gives me a really good background on what's the number in the scale, right? Because many times, and even BMI, right? Once I have those values, I don't really think about BMI or the number in the scale. BMI, what I see most with the fault with BMI and guiding us on BMI is that many times the BMI looks normal. And you think, well, no, this is a normal BMI, you don't need treatment. But when you do more deep studies, like, I mean, the gold standard is an MRI, DEXA is the second one, and then impedance machines are the third one for getting those more diagnostics values in regards to metabolic health, right?
Okay.
So because when I see a normal BMI, it's due to higher fat mass and lower muscle mass.
Yeah.
So that's not healthy, right?
Yep. Yep. So, okay, we're talking metabolic health.
Metabolic health.
What is metabolic health?
So metabolic health, what in a simple way is to say that the ratio of your muscle or your skeletal muscle mass is higher than your body fat mass, right? And that your visceral fat is low, or you don't have visceral fat, or that is normal, right? So
Okay.
that's metabolic health.
Okay. So visceral fat, and that's where you're like the MRI is like can measure visceral fat.
Or a bone density, a DEXA scan, or the impedance machines that works with ions that
Okay.
differentiate between fat, water, and muscle,
Right.
and it makes calculations.
I think it's important to just be redundant. You're not paid by any companies at this point. You don't have any like relationships with pharma companies, right?
Pharma, and I don't even have a relationship with anybody.
InBody. Okay.
But that's the most common accessible for a doctor's office machine brand, right?
Yeah. Okay. Okay. So you have those percentages. I think that's important to kind of like identify clearly what is metabolic health. Is metabolic health have to do with like ability to do a treadmill test or ability to have like hand
No.
grip strength in your mind?
Insulin resistance, A1C, right? Blood pressure, cholesterol. Those are more metabolic values that we can use, or also diagnostically.
Okay. So you're getting this kind of idea of their total metabolic health. And so just to be clear, like exercise, their ability to exercise, is that part of that? Or is the ability to exercise potentially and strength train, is that going to adjust those different things that you're looking at?
Yeah, I mean, it's definitely a good clinical evaluation on a physical exam. You can get a good idea if the patient, I mean, most patients are already set on exercise, right? I haven't met a single patient that I see for obesity and weight loss that doesn't exercise, do some sort of exercising, right? So it's just guiding them towards the right exercise, especially if we're starting a weight loss treatment, right? because on any weight loss, even if it's not, we're not talking just medication, if it's just like a restrictive caloric diet, or there's going to be calorie restriction, then there's going to be muscle loss, right? So it's just guiding the patient on the exercises that would help them maintain or lose the least amount of muscle on the weight loss phase, right?
Okay, so I've seen some studies that show that if you were losing weight and you do strength training, you lose more fat than muscle. And I've seen you post on this. Is that kind of your philosophy? Because there's a lot of people who say like, oh, I should just do cardio.
No, I have all this data from the studies that I do, and it's so beautiful to see how when muscle drops, percentage body fat goes up in some patients. For the muscle loss, could have been they stopped exercising, they went on vacation. So I can see that when the muscle comes down, percentage body fat goes up. And those patients that muscle goes up, percentage body fat goes down. So it opens up the gap, right? So anytime there's muscle gain, there's percentage fat lost automatically without medications. And it's beautiful to see that change in percentage body fat just from muscle gain. So when we move to a maintenance part, in let's say we achieve the weight loss goal of the patient, when we go to maintenance, I always try to guide the patient to gain muscle, because that extra muscle gain, we're going to rebuild the muscle that was lost, whatever was lost, and then gain muscle. That's going to become part of the maintenance part. That extra muscle becomes that second drug, or that extra dose that I decreased, right? It becomes part of the maintenance part.
One of the things that got me excited about talking to you was it had been a while since I had read any articles that excited me with the percentage of weight loss that I was seeing in them. When I think about like 15% weight loss, I think, did they get like some sort of surgery, right? And so I'd seen this semaglutide study where, we're talking about 50% of the people had lost more than 20% or around that of weight loss. What is, I guess, what is your like starting medication that you're thinking about? Or is it like 50% of your patients get put on this first, or 50% of your patients get put on this first? Like, how do you make a decision what they get put on first, and what are you putting them on first usually?
So let's talk about what we have available for weight loss, right? What are our weight loss drugs that we have available that are FDA approved? So we have the GLP-1s now, also the GIP, which is semaglutide, right? That's the FDA approved for weight loss. And we have Tirzepatide, which is the newest one that is FDA approved for type 2 diabetes, off-label for weight loss. We could use it, right? Then we have another medication called Qsymia, which is a combination of phentermine and topiramate, an extended release topiramate. That's an oral drug. And then we have Saxenda, which is liraglutide, which is another GLP-1 that is the daily version versus what we have as a once a week in semaglutide, right? And then we have orlistat, which is one of our oldest medications, right? But it has the bad side effect that we all know, that any fatty meal that you have can give you diarrhea or soiling, right? And they don't work as much for I mean, they don't produce the weight loss that we see with our newer drugs, right? So I don't really use orlistat. I don't really use Saxenda. Definitely, I see more weight loss on the weekly shots than on the daily shots. Significantly difference.
Okay, good. Yeah, so weekly shots, you see better
so
effects.
Whenever I'm doing the history of my patient, and I'm talking into the relationship with food, that's a part also of the consultation, right? I get a sense of the relationship with food with the patient. If in the majority, I would say, of patients with obesity or overweight, they do have some sort of emotional positive reinforcement with food, right? So in those patients, the GLP-1, GIP medications, and semaglutide and tirzepatide work really well, because it works we have receptors in the amygdala for GLP and GIP. So it dissociates any positive reinforcement from food. So any anticipation that you have from food or even alcohol in some patients, that anticipation of getting something emotional, social, some sort of positive reinforcement, it takes it away. So for those patients that struggle with that, with snacking, craving, drinking, this type of medications are great, right?
Wow.
It, it,
That's,
it
yeah.
rewires the way you see food. It changes your perspective of food. You really think of food when you're hungry, but then it increases your satiety hormones. So you get hungry, but then you get full with small amounts. And in between meals, it decreases your hunger hormones. So you're really not thinking of food only when you're hungry, then you eat to satisfy, and then that's the last time you thought of food, right? You still enjoy food. That's a question that I get from my patients. They're like, oh, I'm still going to enjoy food. Definitely, you're still going to enjoy food. You're still going to savor food, but there's not going to be that anticipation or emotional response from food or alcohol.
Yeah. Yeah. So I guess I'll disclose, I've tried this, the weekly injection. I won't say which one. But one of the things that I found is my stomach feels full. It doesn't empty as fast. I don't crave the last meal of the day like I used to. Like, so at like 9 o'clock at night, that lasts like 500 to 1,000 calories or so.
Mm-hmm.
Um, it's like I'm not even thinking like I could put more in my stomach, which is interesting.
And you know
Um,
what's the amazing thing? And that's the biggest difference with bariatric surgery.
ooh,
Because
tell me.
bariatric surgery, and this is the research that I did in job, bariatric surgery, and by the way, this incretins, they're called incretins, they were discovered mostly after bariatric surgery because we didn't know it was just the mechanical restriction that patients were losing weight. Then we found out that it was this hormone, the GLP and GIP, are produced in the L cells of the small intestine. So when the Roux-en-Y, you're making that transfer from food to the small intestine faster, right? So there was a faster release of these hormones, and that's how they were discovered, these hormones, right? That's how we found out
Wow.
that they exist. But the difference with bariatric surgery is that, yeah, you have more release of the GLP-1 and you have a mechanical restriction because they're physically shrinking your stomach, right? I mean, you have a small capacity, a small place to put food. That's the mechanical restriction of bariatric surgery. And while there's more production of endogenous GLP and GIP, it gets degraded within 2 minutes. It has a very short half-life. There's a APP4 enzyme that degrades this hormone, and it doesn't have enough time to cross the blood-brain barrier. Now, the synthetic form, it can go to the receptors in the brain. So we don't get that reward system shut down in bariatric surgery. That's why there's a lot of regain. Yes, because you're restricting them mechanically, but the psyche nothing happened in the psyche. They
Interesting.
still want to eat. They still get that emotional feedback from food. And what happens? Eventually, they regain weight. I'm seeing Roux-en-Y gastric bypass patients that have regained most of the weight back, which the Roux-en-Y was our gold standard, less regain of weight, right? Versus the sleeve or the gastric sleeve. So it's very interesting to see what's the difference, is that this is actually working also in your brain and mechanically in your gut, versus bariatric surgery is just doing a mechanical restriction, but it doesn't change the psyche.
Wow. Okay, so GLP-1, I think, can you just, for someone who hasn't heard anything about this type of medication, like give me the basics on like what a GLP-1 is doing. You've put it in little bursts, but say it again just so that we're all on the same page.
I think it's really interesting to say that these are not new drugs, right? I think there's like this conception that, oh, they're so new, what's going to happen? We're not going to know what's going to happen. Are they safe? Are they not safe? The first incretin, which is a gut hormone, is this type of hormone that regulates glucose. That's the true definition of an incretin. They were discovered in 2005. So since 2005, we've had this sort of medication. The first one was Bayera. That was the commercial name. Exenatide was the hormone name. That was our first GLP-1 that was made in 2005. And it was developed for type 2 diabetes because they regulate glucose control by helping your pancreas make more insulin or work better in the insulin that increases insulin sensitivity and increases insulin production in type 2 diabetics, right? The beautiful thing of this drug is that the effect on the pancreas is glucose dependent. You actually have to have hyperglycemia or type 2 diabetes to work as a diabetic drug. If your sugar is normal, if your glucose is normal, it doesn't touch your pancreas, passes along, right? That's why we can use it independent of diabetes and obesity.
Because you don't get hypoglycemic. And I've seen that in the studies. There's no one getting hypoglycemic.
The only time we see hypoglycemia is if the patient is on insulin or a sulfonylurea, right? Okay. And those need to be titrated down because now the patient is going to be eating less. So if any hypoglycemia is because they're on medication that can cause hypoglycemia, but the drug itself does not cause hypoglycemia.
Yeah.
Okay. And then eventually when we started using them because they came out for diabetes, we knew nothing about weight. As we started using them, patients were coming back with better glucose control, better A1C, and weight loss. And we rarely see that with any diabetes drug.
Never. I think insulin gains weight.
Yeah. And then we had the PPR, the pioglitazone. Those medications can also make you gain weight, sulfonylureas. So any medication can cause hypoglycemia, can cause weight gain. And then the pioglitazone can tend to also to gain weight. So we really didn't have any diabetes drug that actually also causes weight loss. So then we started seeing that clinically that the patients were coming back with weight loss and better glucose control. Then we branched out off label to start using it for independent of diabetes for weight loss. Then the studies came out, right? From liraglutide was the first one. The one that we started was named Victoza, is still on the market. Victoza was a daily injection. And then they got the FDA approved with the studies for Saxenda, which is the FDA version approved for weight loss. Then in 2017, they brought the same pharmaceutical, they brought semaglutide, which is a longer acting molecule, right? That is just once a week. And it was FDA approved for type 2 diabetes. Again, we started using off-label for weight loss. Then 2020 came the indication, the FDA approval for obesity, and the rebrand. Every time they the indication for obesity rebranded, but it's exactly the same molecule, right?
Right.
And now the newest one that came out this year, it's the first combination drug. It has GLP and GIP, which all the other versions were just a GLP-1. So this is our newest version, which twincretin they call it because it has both incretins in it.
This is the
Tirzepatide.
Tirzepatide, yeah. And that, like, I was looking at the study you sent, 2,539 participants, average age 45, 40% with prediabetes, average weight going in 231 pounds, and the change in waist circumference in the 15 milligram group. So there were 3 groups and a placebo group. In the 15 milligram group, almost 7.5 inches off their waist.
21% weight loss.
And that was pretty impressive. We will put links to these studies on our website, psychiatrypodcast.com, as well as a link to your website. And so when I was looking at that, I was like, wow. And interestingly, okay, so you may, as a patient, be like, okay, how do I get this? And first of all, this is medical information. We're not your doctors. You should go talk to your doctor. They may be expensive. And if your insurance doesn't cover, I actually I ordered through Canada. I don't know what you do. If there's a cheaper way, let me know. But I have a couple of patients who've ordered from Canada because it's off label, at least Ozempic.
Yeah.
I don't know. How successful are you getting these paid by insurance companies?
So there's a bit of a loop right now that it's beneficial for patients with Tirzepatide. And again, I'm not sponsored by any pharmaceutical, none.
Yep.
I just use these drugs and I see what they do, right? I mean, this is what I do day to day. They work. What Tirzepatide is doing now for 1 year for patients with commercial insurance, they're not doing prior authorization. It's just a $25 coupon per month for 12 months. So that's what Tirzepatide is doing.
Yeah.
The problem with semaglutide is that they came out with Wegovy, that's the FDA approved for weight loss version of semaglutide. They ran out of stock. They ran trouble in production because they didn't anticipate the usage, the demand, right? So they shut down production, and actually all the patients that we started on Wegovy, most of it had to default into Ozempic. And now there's even shortage of Ozempic, right? So now, and even now, doesn't matter if you can actually pay for it, can we actually get it, right? So there's loops that you can work by to having patient access to the medication. I mean, it is an expensive medication, right? But it's truly an investment in health and versus the money that patients have spent through the years in diets.
Sure.
Exercise
that don't work.
That didn't work. This is actually is going to work, right? And that at the long run, it may be cheaper than continue to do all those diets.
Right. People, and if there's anyone in the insurance companies listening to this, like, please, like, why would you not? The problem with insurance companies is they're not thinking like, we're going to have this person on this insurance 30 years from now. And, they're going to be more prone to more complicated diseases, which if you get to the ICU, it's really, really expensive. So the problem with insurance companies, they're not thinking like, this is going to help this person.
Well, I think
reduce
it's not
costs 30 years from now.
It's the healthcare system also, right? We as a healthcare system, we got comfortable, and as physicians, we got comfortable patching all the complications for obesity. Right. That's the only thing we had, right? We had diabetes medication, we had hypertension medications. We got comfortable doing that. I feel like we built fellowships on the complications of obesity, right? But now actually we have medication to treat the cause, which is obesity, right? So I feel like us as physicians, we have to change the mentality and the way that we see obesity and treat it as what it is, right? We would never think twice of treating somebody with an A1C of 9, right?
Yep.
We'll start them on medication. But with obesity, we still have like, oh, let's try the non-medication way, right? So I feel like us as providers, we have to remove that bias in obesity, right? And then once there's more demand of the physician prescribing this drug, more demand from the patient for this drug, I feel like insurances will cut up too, right? But if us as physicians don't prescribe it, don't think the use of it, we're still thinking of obesity as a lifestyle problem and putting everything in the patient's shoulders, then there's that disconnection of, it's a great drug, but we're not receiving that demand from it in orders, right? So I feel like there's many pieces of the puzzle that's going to have to fit together if everything changes, right?
I know I only have a couple more minutes. I think it's important to talk about side effects, and then maybe I'll have you come back for part 2 and we'll talk about the these other meds. Side effects of GLP-1s, nausea, because you have slow emptying, potentially if you eat too much, vomiting. But there's, I guess in rat studies, there were some like cancer. Can you speak to that?
So there's medullary thyroid carcinoma, which is a very rare familial type of thyroid carcinoma, aggressive. But since 2005, with the first incretin, there hasn't been a single human case report of medullary thyroid carcinoma. Like in your history, you always have to ask about family history of thyroid cancer. And if there is, if it's papillary follicular hurdle, there's no issue with that. If it's medullary thyroid carcinoma on a first degree relative, then that patient is not a candidate for it, right? But we don't do screening ultrasounds. we don't go and screen for nodules and biopsy them before we start this medication. Again, not a single human case has been reported in almost 20 years.
Okay. So what are the common side effects, and do you have any tips on how do you deal with the side effects with the
I want to
GLP-1s?
talk also about pancreatitis. That's another big one,
Okay.
right? Pancreatitis. In my 12 years of clinical practice with these medications, I've seen 2 cases of pancreatitis, and there were on patients with type 2 diabetes. Remember, if you don't have diabetes, it doesn't touch your pancreas. So very rare, right? And I've only seen it on patients with type 2 diabetes. Now, the day-to-day side effects, nausea on semaglutide specifically, significant less nausea on Tirzepatide. Significant.
Oh, wow. Okay.
Dehydration is the biggest one that we don't talk enough about, and the one that can put patient on more complications. It can cause severe dehydration that patients can develop kidney stone, have lightheadedness, have syncopal events from dehydration. As it takes away your hunger, it takes away your thirst. So you may not feel thirsty all day, even though you're dehydrated, right?
Yeah.
And that's an effect of the medication. So there has to be conscious hydration. I always tell my patients that I'm going to write it in a prescription. Fluid intake is part of the treatment, right? Dehydration is going to make the patient feel run down, tired, fatigue, and then it can get worse to develop kidney stones, acute renal failure. I have never seen renal failure. I have seen kidney stones, but loss of consciousness from dehydration, and then the patient can fall and hit their head, right? So dehydration is very simple. It sounds silly and simple, just water, but it can really make it very difficult for patients at the beginning, more than the nausea, more than the gastric side effects, actually.
Yeah, that's really good. Okay. Well, we have like 3 more minutes. I want to honor your probably next patient encounter. But I do want to have you come back. And so, yeah, anything else you'd like to say in the last 3 minutes?
I think very important is to tell patients regarding insurance is to make sure that their insurance coverage, when they're time to renew, that they add weight loss medication coverage, right? Employers, for their employees, they should open more of those benefits, and then we don't run into denials, right? So that's a good way of getting patients their medication. And very important, I feel, so the drugs work well, they're relatively safe. The experience in the provider giving you the medication is key. It's gonna make a huge difference. In some places, you don't need a prescription to get it. I do not recommend that. There's still drugs, and they still have side effects.
Yep.
And then you may not even have results because it's not being used properly, right? And you can get into a lot of trouble. So they're great drugs. They work great, but they're still medications, and they still need medical supervision.
Yeah, 100%. And I would now, what states do you see clients in, or do you do coaching worldwide, or just
Medicine, I have in California, Florida, Vermont, Georgia. So I do
in New York? Okay,
in New York for sure, yeah, and New Jersey. So I do telemedicine too, but also in person.
great. Okay. Well, hey, thank you so much for coming on. It was a pleasure having you, and we will have to come back for part 2. And so if you have any questions for part 2, shoot me an email. You can contact me through the website, psychiatrypodcast.com, and I will start to just curate those questions for part 2. Thank you so much.
You're welcome.